Good afternoon, everyone. I have not made a methodical presentation as the previous speakers did, actually. But I know that I can do a justice to whatever topic which has been given to me. Ultrasound guided maxillary and mandibular nerve block. How many of you really practice this particular procedure? Yes, I think Ravi, without doubt, I think he should be doing. And not many people are doing. Probably, are we doing it in the right way? So this is the question which I want to address at the end of this 10 minutes. The indications being chronic maxillofacial pain syndrome, surgical related pain, post-operative, then post-herpetic neuralgia, sometimes rescue blocks when your Gasserian ganglion block fail. And these are only terminal branch blocks. We are not actually targeting the foramen ovale at all. So what are the access points? Lot of literature started coming in, particularly targeting ultrasound-guided interventions for V1, V2, and V3. But these are only terminal branch blocks. Lot of difficulties in accessing these points. The first publication in 2013, Nader et al. Actually targeted the pterygopalatine fossa. So targeting the pterygopalatine fossa from here, just targeting two important structures. The one, the anterior border of the mandible and the maxillary tubercle. Try inserting a needle under ultrasound guidance, either in plane or maybe out of plane, and get into the pterygopalatine fossa. And these are not terminal branches. This pterygopalatine fossa injection means that it can provide pain relief with 6 to 8 ml of local anesthetic with or without steroid. But lot of controversy, lot of emergence of literature over the last 12 years meant that we have to refine our technique. This is a YouTube downloaded video. This is to demonstrate the pterygopalatine fossa injection. Practically, this can be done for post-surgical pain. When you are doing a mandibular or maxillary nerve related territory associated surgery, you can give it for post-operative pain relief. So that is the only utility of this particular block. You can choose the anterior border of the ramus of the mandible and then the maxillary tubercle. You have a small window passing between. Just put in your needle either in plane or out of plane and give the injectate around 6 to 8 ml of 0.25% bupivacaine, which will enable good pain relief for the next 24 hours. Can you increase the audio, please? Volume? Yes, that's the place which we target. That's called the pterygopalatine fossa.
Is complex and beyond the scope of this video, but here are the basics you need to know. The main function of the SPG is a relay station for preganglionic parasympathetic fibers that come from the facial nerve, cranial nerve 7. They run through the pterygoid canal to synapse at the SPG. Postganglionic fibers then hitchhike along the ophthalmic and maxillary division.
Yes, but this particular technique I really don't advise, advocate, or recommend for any of the practitioners. So there is some new literature which has emerged over the last 5 years by a lot of people from the west and eastern side of the country. You got literature emerging from Abdullah, you got literature emerging from Kevin Chang, which actually teaches this particular technique. Use a convex probe like this. You just need to keep it anteroposteriorly, just below the zygomatic arch in front of the tragus. You will see an excellent picture of this particular view. Sorry for not having an ultrasound to demonstrate it live because of non-availability of the equipment. I'm trying to show you what exactly we are going to see. This is anterior aspect and this is the posterior aspect. You could see the condylar process here. And you could see all the muscles of mastication, the superficial and the deep heads of the masseter, the temporalis muscle, and the wedge-shaped lateral pterygoid muscle which is getting attached to the lateral pterygoid plate. This is the anterior and this is the posterior aspect. Two important landmarks which you need to see and target is the anteriormost part being targeting the V2 division of the fifth cranial nerve. And this is the posterior aspect which will target the V3 division, that's the mandibular nerve. So how exactly do you really see this? When you see, you could see all these muscles if you have a good ultrasound machine. And apply color Doppler, you could see the sphenopalatine artery, which is pulsatile there. And the moment you see that, this is exactly how you could visualize the sphenopalatine artery being so pulsatile. It's a highly vascular area, but don't be afraid at all. Even if you actually go through the artery, never mind, unless you are giving a neurolytic block. I really don't advise you to give a neurolytic block for fear of adjacent vascular structures. So once you have the color Doppler visualized, you have as this is the maxillary tubercle, this is the anterior border of the mandible, and you could see all these structures around. Then your target for maxillary nerve block should be right at the anteriormost aspect of the lateral pterygoid plate. Exactly, this is the most important picture which I wanted to show you here. This is the lateral pterygoid plate, anteriormost aspect for V2, the posteriormost aspect for V3 division. Yes, this particular video was shared in person by Dr. Kevin Chang in a personal communication. After you see these structures, there is a small little window here between the condylar process and the coronoid process. Target to reach the anteriormost aspect of, see the obliquity of the angle of the needle. This is your target for V2. Right? Now the procedure is live. You could see the muscles here, the sphenopalatine artery, and this is the lateral pterygoid plate. That's the needle tip which is hitting the lateral pterygoid plate on its anteriormost aspect. We have to be very cautious, very slow. We need to see a small little platform-like structure, that's a lateral pterygoid plate, and your aim is to actually hit the lateral pterygoid plate on the most appropriate site. The anteriormost aspect for maxillary division and the posteriormost aspect for the mandibular division. My last slide. Right? The same way. And when you actually do a RF stimulation is mandatory. Once you do a stimulation, you can do a conventional RF. The same results which we will get in a conventional RF of the Gasserian ganglion you will get. But the only difference between a Gasserian ganglion block and a terminal branch block will be the needle position with respect to the position of the nerve. It may not be essentially parallel or perpendicular to the nerve. So you need to be very cautious about post-procedural dolorosa. Can you see that? That's the lateral pterygoid plate. I am trying to target the posteriormost aspect for the mandibular nerve block. Yes, this is an in-plane needling which I am trying to hit the posterior aspect of the lateral pterygoid plate. And the same patient, I actually did an oblique plane needling. You cannot see the needle passing by here. It will actually be seen only after it passes through the lateral pterygoid muscle. So this is how you end up doing the maxillary and the mandibular nerve blocks. Thank you so much. Specifically, I avoided all the literature associated with the complications, the side effects, all that. I think a lot of literature exists, but it's most importantly how exactly you go about doing the procedure is of importance. Thank you.